It's an absolute pleasure to welcome you all here today. I am Professor Zara Quigg from the Public Health Institute at Liverpool John Moores University. I'm hoping this day is going to go swimmingly, but I've just noticed my first typo. It is not the 10th of July, it is the 10th of June. So just so we all know, we are in the right time and space. But it is an absolute pleasure to welcome you all here today, and a privilege for our university to co-host this conference alongside the Merseyside Violence Reduction Partnership. It's the second regional conference that we've held, and I really want to start by recognising the broad range of people and organisations that we have here in the room today. We have people from health, from education, from local authorities, community organisations and charities and community members also, as well as academia. We had to significantly increase the conference capacity from last year, which is really testament to the strong partnerships that we have here in Merseyside. So I know there's a lot of us, but actually that's really important so we can build on our work and build on our relationships. Bringing us here today is so important, because violence is not the responsibility of a single person, a single team, or an organisation. It's a preventable public health, human rights and criminal justice issue that requires a shared and coordinated response. Over recent years, we've seen a real shift here in Merseyside in how we think about violence and how we prevent and respond. And critically, we've got a better understanding and awareness of that violence is actually influenced by a broad range of factors. But critically, it's influenced by inequality and poverty, adverse childhood experiences and trauma, a lack of opportunities across our communities, amongst other issues. We also know that, however, that when we take a prevention-focused, strength-based public health approach, we can make a real meaningful difference to our communities. And here in Merseyside, we're starting to see a real strong shift and a real strength in this area. Through partnerships, we're really starting to build a strong evidence base in relation to violence prevention. We know a lot more about what puts people most at risk of harm, but most importantly, we also know more about, and increasingly more about, what protects people from harm. We've got a better understanding of which interventions actually work for our communities, but also which interventions are potentially harmful and we actually shouldn't be implementing, which is really, really important to understand also. But evidence on its own, it's not enough. It's actually what we do that with our evidence which is most important. Research and data alone can't change things. We have to ensure that we're using research and data to influence our policies, our strategies, our services, how our practitioners work, and how we engage and support our communities. And that's why today really matters, because this is where evidence meets practice. It's where we're all going to share what works, but also what doesn't work. We're going to learn from each other. And critically, I really hope that we're going to build on our relationships that we've established so far, so we can strengthen what we can do and we can protect our communities and make them stronger. At the Public Health Institute, we have a strong and vested interest in developing research and evaluation that's not only robust, but also useful. And that is grounded in the lived experiences of our children, our parents, our families and our communities here in the region. You're going to hear today a broad range of presentations and inputs from right across the partnership here in the room. And you're also going to hear some new research that we're implementing in our institute, including data from our National ACE survey and our survey with the Violence Reduction Partnership, which this year focused on examining children and young people's views and experiences. Really, really excitingly, right across the day, we're going to have children and young people here with us to really help shape our understanding and the work that we do, to make sure that we're listening to their voices and responding to their needs. Critically, we need to ensure that we're working with and for our communities. It's so important when we're trying to prevent violence. So ensuring that we can listen to our communities is paramount. We know from the evidence base that early intervention, strong, stable environments and families and relationships can really change life trajectories in a positive way. We also know that community-led, partnership-based approaches do work. Critically, we know that when we bring systems together, systems from all the organisations and the community representatives that we have here today. When we bring us together, when we're sharing knowledge and we're aligning what we do, that makes the greatest impact. That is so important. We can't do these things alone. We are better together. So today is really about building on that. But it's also about challenging ourselves and really thinking through, are we using the evidence-based in the most effective way? Are we intervening early enough with the right interventions at the right time? And are we working in the most joined-up way possible? So I'm going to encourage you all today to learn, but also connect and share your experiences. And critically to think about how can we work better to keep improving the lives of our community. So I'd just like to thank you all for being here today and for all the work that you do on a daily basis. I'd particularly like to acknowledge that this conference is truly a collective effort. We've been engaging with most people in this audience to bring this together. So I really do want to thank our near 70 contributors today and all those behind the scenes who help support the day. I'd like to thank all our chairs and our attendees, not only for your time, but for your dedication for improving the lives of our communities, for making our communities safer, healthier and happier. I now have the pleasure of handing it over to Emily Spurrell, our Chief and Crime Commissioner, who will give us more details on how we're going to take violence prevention forward in the future.
So, hi, morning everyone. So lovely to see so many of you here. Lots of familiar faces, lots of new faces as well. And I was reflecting as we were all coming in, just you can feel the energy and the buzz in the room. And I love that about this event because you can feel the passion from all of you, whatever role you play, whether it's a statutory, third sector, voluntary sector, you all do such an incredible job trying to tackle the serious issue of serious violence. And it's just brilliant to have so many of you all in the room here today. And that's really what today is all about, not just sharing ideas, but also strengthening that collective effort that Zara has already spoken about. Every single person in our region should feel safe in their home, in their school and in their community. But sadly, we know that the reality for far too many people is that is not the case. And we know that violence doesn't just affect individuals, it affects families, neighbourhoods and entire communities. It leaves lasting trauma, it limits opportunity, and it creates cycles that can be incredibly difficult to break. And we see that in the work that we do every single day. So last year, I know lots of you were here, we came together under the theme of driving change, which is all about showcasing the impact of prevention through the work of our amazing violence reduction partnership over its first 5 years. But this year, we want to take the next step. Because across Merseyside, working with LJMU and many other partners, we now have a really strong and growing evidence base. We understand far more about what causes violence, who is most at risk, and crucially, what works to prevent it. But again, as Zara said, evidence on its own doesn't change lives, action does. So today is all about how do we take everything that we've learned and translate it into consistent, meaningful action across every service, every sector, and every community. And so that's why today is such an important moment, because today we are launching our brand new Merseyside Violence Prevention Strategy. This is not just another document, it is a shared commitment, it is a long-term plan that sets out how all of us collectively will prevent and reduce violence over the next decade. At its heart is a simple but powerful belief: violence is not inevitable, it is preventable. And I should say, you might be wondering where the strategy is. It is literally hot off the press and will be arriving any moment now. So hopefully in the break you'll get a copy of it to consider. So what the strategy does, it gives us a clear and a shared direction. It's grounded in evidence, it's shaped by communities, and it's built on the partnerships that we have all worked so hard to create. It focuses on early intervention, stepping in before harm happens, a life course approach supporting people from the earliest years right through to adulthood, and it tackles the root causes, including trauma, inequality, and lack of opportunity. And it recognises something that we all know, and that again Zara's alluded to: no single organisation can solve this challenge alone. This is about a whole system response, where every part of the system plays its role because the scale of the challenge is significant. We know that by preventing violence, we could save our region more than £200 million every year. And for every pound invested in prevention, more than £4 is saved. But of course, beyond the economic value is something far more important, and that's the human cost. The lives affected, the futures changed, the opportunities lost. And that's why prevention isn't just important, it's essential. I also want to recognise how far we've already come. Over recent years, we've made real progress in reducing serious violence. Since June last year, knife-enabled offences have reduced by nearly 5%, And we've seen a consistent reduction in the number of under 18s who are victims of violent crime. And this isn't happening by accident. This is down to the hard work and determination by all of you in this room and the organisations that you represent. People who are delivering real change day in and day out. But we all know that we can't be complacent, and there's always more that we can do, and that's why this strategy matters, that's why all of you matter, that's why all of you are in this room here today, because the strategy will only succeed if it is lived and delivered across the system. Not just today, not just at a strategic level, but in everyday practice, in how we work, in how we collaborate, and how we support the people who need us most. In how we get upstream, intervene early, and stop violence happening in the very first place. Over the past 6 years, our VRP has reached more than 200,000 young people through its interventions. 200,000 young people, which is an impressive number. And through innovative programmes that have been trialled, tested and evaluated, we know what works and we can scale it. And today you're going to hear about that work in action. Initiatives focused on early intervention and family support, health-led approaches, supporting children and young people, and breaking the cycles of offending. You'll hear from experts, practitioners and young people themselves, sharing not just ideas, but real examples of what's working. And the data and evidence is critical to all of this. Through its work with LJMU, the VRP ensures that programmes are properly evaluated, so resources are directed to where it will make the biggest difference. And we are incredibly fortunate to have expertise like Zara's here in Merseyside helping to drive this work forward. And you'll be hearing from Zara's team shortly to speak in more detail about how we can harness a public health approach to prevent violence. I'd like to finish by taking this opportunity to thank all of you. As I said at the beginning, you can feel the energy of the room, and I know so many of you are absolutely tirelessly dedicated to the work that you are trying to do to reduce serious violence and protect our communities. You are changing lives, you are increasing opportunity, and you are preventing harm. We are all here because we care deeply about our region, and we all want to make it a safer, stronger, and more connected region. This is a powerful opportunity to learn from each other, challenge ourselves, and turn evidence into action. Because if we get this right, we can break the cycle of violence, not just for today, but for generations to come. So thank you for everything that you do, and I hope you find today inspiring, insightful, and above all, actionable. Thanks.
Thank you, Emily. Before we move on to our first plenary, I'm just going to go through some housekeeping. If you can all put your phone on silent or vibrate, that would be appreciated. There's plenty of space in the foyer should anyone need to take a call, and that's totally fine. If you haven't found them already, toilets are just by the lifts as you go outside. We are in a sustainable building. It's an absolutely beautiful building with really good facilities, but we also ask that you respect the building as well. So please, if there's any spillages, etc., please inform the spine staff straight away, just so we can keep the building as it is. Lunch will be served on 2 layers, so we're on floor 13 at the moment. Lunch will be in the main room that you may have seen previously, but also downstairs. And our parallel sessions will be in this room and in 2 rooms below. So we have both floors for our conference today, and please do use the conference space as you wish. Just in terms of the conference, I know we did start slightly behind, but we have a super packed agenda, so we do need to keep to time throughout the day. There will be time for questions and discussion, but we may have to limit that time and push those discussions into the break or the lunch. So I do wish you to enjoy the conference. And critically, we know we are touching on a really sensitive topic right throughout, so please do take care of yourself. If you do need any help and support throughout the day, please come to myself or another member of the John Moores team. We'll be happy to help. We're not expecting a fire alarm, but should the fire alarm go off, you'll hear 2 different messages. One for us to remain in the room and where we are, another that we need to leave immediately. And if we do need to leave, you need to go out to by the lifts to the stairwell and head down. If you're not able to use the stairs, again, just alert a member of staff and relevant procedures will be put in place. The meeting point, if there is a fire alarm, is just facing the building where you would have entered. So I think that is all the housekeeping, but if anyone has any questions, please do let us know. I'm now going to move us to our first plenary session, which is really about how we harness that public health approach to violence prevention here in the region. We have 2 keynote presentations, and then we'll have a brief time for Q&A, and then we're going to go into a broader panel discussion followed by a short film. This session is going to run about 5 minutes over. I do apologise in advance, but if anyone does need to leave for a drink or any comfort, please do so at your leisure. But if I can invite Professor Mark Bellis to the stage. Thank you.
Thank you very much. It's fantastic to be here. Fantastic to see so many people from so many different backgrounds here, and celebrating as well as learning. I think that Merseyside has taken such a lead with groups like ourselves at LJMU in public health approaches to violence prevention. People have talked, and I think it's a great title, Breaking the Cycle. And it doesn't matter when you break the cycle. That's the great thing about cycles. If you break them, you can pick at any stage, and that's why we need to focus, if we can, on all stages. But today, I just wanted to use some new information we've been collecting across the UK and elsewhere, just to focus particularly on 18 to 30-year-olds. So I'm going to dive straight into that because Zara's a firm but fair taskmaster on time, so I will try my best to stick to it. Right, so I'm assuming lots of people will know about ACEs, but I can't assume everybody knows about them, and I'm going to focus mainly on adverse childhood experiences. But just as a brief recap, so we're talking here about this is a kid at rest, and we'll assume all sorts of things can cause trauma or upset or stress to that child, but we'll assume they have to walk past someone who's particularly unpleasant, aggressive on the way home. And they go into a flight or fright sort of format where cortisol and adrenaline and all sorts of other things pick up. But by the time they get home, things should be like this, exhausted but going into recovery. Of course, if that person happens to be one of their guardians living and popping into their bedroom all the time, that's a completely different issue. And what we get then is called the fixed allostatic load, which means they never come down to that level. And systems which are set at high response levels permanently wear out more quickly. As a result of that, we get children who develop into adults who have a heightened state of alert, and that causes a variety of health problems. I'm not going to go through all of those today, but I'll just touch on the beginnings of them. We get people who look at neutral faces and think they are aggressive, or even think that violence is the right way to solve issues. We get people who are anxious and disengaged at school, and so they can't focus, they can't learn. They're sometimes, if people are not trauma-informed and responsive, thought of as troublemakers. And they don't trust the communities, they don't trust people around them, they don't trust other people, they don't trust particular groups. And just the little pictures at the side are just to say, these are not just psychological changes, they are changes that affect people's physiology, they affect them at the genetic level, and they affect them at the way their brain can develop as well. But it is not a pathway which is set and can't be changed. This is taken from one of the reports we did with the World Health Organization, and really it's just saying that the same thing really. We've got developmental issues early on in life, we've got problems on the endocrine side and with performance in school and things like that. And then we've got the beginnings of health issues. We've got criminal behaviour and antisocial behaviour. We've got things like the beginning of parenting and a variety of other things. And then later on in life, there may be long-term economic consequences to those things. And sadly, later on again, there might be multiple health issues and even premature mortality. But what I want to talk about really is the 18 to 30-year-olds, because we talk a lot about particularly young children, and we also talk quite a lot in health about what happens later on in life. But there's good reasons to talk about the 18 to 30-year-olds. They're people who've just suffered ACEs a lot of the time. It's the first time they're in employment, a lot of them. It's the beginning of long-term health conditions. It's the beginning of a variety of relationships, and they're often at the time at which we're having new children. So that cycle is starting again. To remind people also about adverse childhood experiences, these are the ones we're talking about. Things like physical abuse, sexual abuse, verbal abuse. And none of these are insignificant. We're talking about 1 in 5. This is UK data. This is the latest combined data, so it's on about 28,000 people in the UK. So about 1 in 5 physically abused, about 1 in 5 verbally abused, just less than that seen physical abuse, as in domestic violence in the household. And really important, because I'm going to come on to these, suffered things like mental ill health in the household, some often an adult in there, or alcohol problems, or drug use, or criminal problems in the household. Figures many of you will be familiar with, about 10% of people in the UK have suffered 4 or more ACEs. 4 or more ACEs is an arbitrary number, but I'm going to focus on it like many people do. Doesn't mean there aren't harms at 3, 2 or 1 ACEs, but it's easy to compare that just for the amount of time we have. And people have mentioned poverty and deprivation, and basically people who live in the poorest communities have about twice that level on average, so about 20% instead of 10%. And that really, if nothing else, tells us it's a public health issue. We can't provide a specialist service for 1 in 5 of all people in the country. Another brief update before we get on to the new stuff. We need to get in early. Kids, and this is at the childhood stage, 3 times if they've got 4 ACEs more likely to have long-term headaches, 5 times more likely to report that they had long-term health conditions when they were young, and 7 times more likely to be routinely absent from school. So there's already a price you pay. It doesn't mean that trauma-informed responses later in life aren't important. It just means that there's a cost that's already been paid. So for the rest of this talk, I'm going to focus on a new study. We are working with the World Health Organization and the European Union, and the study is running across the entirety of Europe. But at the moment, we've run the study, but we piloted it and collected additional information in the UK. It's on 18 to 30-year-olds. It's based on a panel survey. I can talk about what the implications of that are. All the figures you see will be corrected for child poverty. They'll be collected using something called the ACE-IQ tool. I'm going to talk a bit about resilience, and I'm going to talk about quality of life measures and costs, but we'll come on to those as we go through the next 8 or 9 minutes. So, the first thing is, let's look at childhood violence. These are kids who may have suffered lots of ACEs, and we'll look at those. So most of the graphs are going to be the same, from no ACEs to 4 or more. And we can see that goes from about 15% have been in physical fights. This is when they're under 18, so when they're still kids, routinely in physical fights. So adding to the physical violence they're exposed to when they're at home, going from 15 to 45%. It's different for boys and girls in this particular case, going from 66% in men in young lads down to 26% in girls. And again, I'm going to use the same format for all these slides. It's easy to calculate from that what the average is at the moment, so about 27%, and it would drop if we got rid of ACEs to 15%. So you can see there that not quite, but nearly 50% of violence in young people is likely to be related to adverse childhood experiences, over and above what they're suffering at home. This is being bullied, so we're looking at the recipient side now. Again, going up from 7% up to about 32%. But in this case, the sex basis is much more even, so more or less the same numbers of boys and girls suffering the outcome. However, again, if you look here, 16% is the average that we are seeing in the UK sample at the moment. If you took out the effect of ACEs, that would drop down to 7%. So more than 50%, you could at least suggest at this point is down to that. I said I'd talk a little bit about other types of things. So there isn't really time to go into things like cyberbullying and stuff like that, but I will cover some of it. And if you look here, I'm just showing that the levels have gone up from 24% to 48%. So only here to point out that we have a relationship between people suffering what you might call physical ACEs and the relationship they see also in higher risks of online issues as well. Roughly the same number of people under 18 suffering those two, suffering cyberbullying. But the impact, because it's in fact impacted by many other things, is down to other issues. Now, I'm already down to 5 minutes, which is quite frightening. So I'm going to speed up a little bit. So this is adult violence now. And again, I'm going to rush through these. So you can see this is in the last 12 months, hit someone. Males, as you would expect, much more likely to be higher, 9%, but almost down to nearly 1%. So the truth here is if you take ACEs out, you would probably reduce the levels of people hitting each other by nearly 3 times. And again, frightening someone, so this is actually not hitting them, but threatening people, we can see a similar drop, similar sex difference, but a drop of nearly 4 times between the two. So what we're seeing in adult violence is related to ACEs and to childhood violence. This is the passive side, so being hit. Being hit increases with ACEs as well, 11%, 24% in males, and up to 7% from around 2% if there were no ACEs around. So, and again, for people who might think that's surprising, partly it's because if you hit someone, you're probably going to get hit back, but also you put up with violence more, particularly in domestic settings, if you thought that was going to be the case. Frightening someone shows exactly the same pattern, higher in men than women in this case, but up from 5% from an average of 12%. So again, more than half down to what people experience as kids. But for those who come from slightly different backgrounds, it's worth building in these things as well. This is low-income households by ACEs. So 9% with no ACEs, and this is in 18 to 30-year-olds, remembering that they're in their first jobs, their first income. Students and things are taken out, up to 20%. Almost exactly the same whether you're a man or a woman. And that's up from 15%, our overall mean at the moment, but could be down to 9 in terms of low income if we thought about what we did with kids. Unemployment, 13%, down to 8% in those with no ACEs. So our economic issues are also related to that. If you're looking at 18 to 13-year-olds, you should expect them all to be relatively healthy. Not all of them, but most. But these are the differences if we use health measures. So we've looked at economics and violence health. This is impaired motility of any level, 6% in no ACEs, up to 25%. The ones I want to point out are in pain and discomfort, up from 30% to 53% with 4 or more ACEs. And this one at the bottom here, anxiety and depression, up from 45% to 78% in those. So 3/4 of people have some form of anxiety and depression if they came from that. It's high anyway, but we have a lot of mental health problems. Now, I definitely haven't got time to go through the mechanisms of this. And please ignore those figures because they're the old ones. So forget you've seen those figures. What you should be seeing is a figure that says that for every person with 4 or more ACEs between the ages of 18 and 30, it costs us roughly, just in health, about £10,000 per year. Right, so if you're trying to think about what you're saving, if you stop someone having 4 or more ACEs, over the period 18 to 30, you'll save £140,000 just in health costs. So let's just quickly go on to this and imagine this. These are 18 to 30-year-olds. They've got a greater association with violence, problems in their own childhoods. We know that they've got much higher risks of low income. They've got poorer mental health and physical health. It says 2 minutes here. And in the middle of that, we drop new parents with all those problems in the middle. And that is really just another way of looking at the size of the cycle we're trying to break. So how do we do it? Early prevention, and I'm not going to go into this, certainly not in the last minute, and people here I'll sure be talking about today. Trauma-informed responses and building resilience. These are 3 measures of resilience, which we picked up in the European study and the UK one we ran first of all. One's, again, people are thinking about just some adult that is always there that you trust in your life, that you have at least one parent or guardian of some point who you think understands your problems, and that you have one parent or guardian who takes an interest in caring and knowing where you are or what you're doing when you're a child. 3 basics, really. Now, all I want to show is the colour change from green to red on these. So this has been in fights when more than rarely in the last when you were under 18. And you can see, even if you've got 4 or more ACEs, you can reduce that from 50 to 28%. If you take out the ACEs and put all the resilience in, you'll take that level down to 10% from 50%. Similarly, if you've hit someone in the last 12 months, this is older ages now, you can bring high resilience, low ACEs down from 11% to 1%. And similarly, again, if we're talking about how much health you've lost, and this is a difficult thing to explain in 18 seconds, but essentially what this is saying is for every year you live, you only really experience 3/4 of a year of healthy life. You can drop that figure from 41% to 5%. These are all avoidable. So this is my final slide, Zara will be delighted. Violent traits are frequently rooted in childhood, and ACEs, and expressed in childhood as well. We often talk about violence in adults, but this comes out long before that. ACEs are facilitated by other factors and what they cause an interpersonal violence, like poor school attendance, mental health and other things in schools. There are strong links between ACEs and other cyber themes, which I can't go into today, but they are linked. Ending ACEs should cut violence by more than 50% in most cases. There aren't many things you could say that would do that. There's a compelling economic case for countering ACEs, and it is accompanied by greater employment, better incomes, and considerable health savings. All of these things will save money and produce, for those who are interested in those things, more income, more taxes to come in, more money for more public services. Everyone should understand the importance of resilience. It's necessary to be trauma-informed and responsive. But if I can just take you all the way back to the beginning and finish on this, it is also important that we get in early, because those harms start straight away, and the consequences of those start very early as well. Thank you very much.
Thank you, Mark. A lot of interesting information to digest there. If there are questions, if you can just hold them to after our next presentation. And I'd like to invite Dr. Jane Harris to the stage.
Good morning, everyone. My name's Jane Harris and I'm a research fellow at Liverpool John Moores University. And I'm just going to be giving you a brief overview of some of the learning from the past 7 years of evaluating the Merseyside Violence Reduction Partnership as a whole system. Just before I do, just to acknowledge this evaluation as a team effort, and in particular, I'd like to acknowledge Professor Matthew Millings, as a lot of his thought has underpinned this presentation. So as Mark's overview of ACEs has shown us, the approach in the UK is increasingly moving towards multi-agency public health approaches to violence reduction. So this example here on the slide comes from the Serious Violence Duty, and its predecessor, the Serious Violence Strategy, of course underpinned the development of the 20 violence reduction units across England and Wales. The most recent national evaluation of VRUs shows us that there have been reductions over the life course of violence reduction units in sharp object assaults and admissions for violent assault among young people. However, what we know from policy is that often it's easy to assume that the pathway between the action and the desired outcomes is a straightforward one, but we all know that in practice that's rarely the case, and often the pathway between the action and the outcome is much more complicated, and there's a lot of actions and short-term outcomes that we need to achieve along the way. So today I'm just going to give an overview of 3 factors that our 7 years of evaluation have told us helps the Merseyside Violence Reduction Partnership work as a public health approach. They are leadership, cultivating an environment of professional curiosity and learning, and embedding evidence-based practice into decision-making. Because I've only got 10 minutes for this overview, just to acknowledge that I'm only going to look at what works, but obviously, as you all know, any partnership also comes with its challenges, and the panel session following this talk will talk a bit more about those challenges and some of the solutions. Just before I look at those 3 factors, I just want to acknowledge that context is important. So violence reduction units across the country will share their best practice to develop national guidance, but the Merseyside Violence Reduction Partnership is first and foremost a Merseyside story, and we can't ignore the things that have happened in the past 7 years that have shaped how the partnership has developed. So we know here in Merseyside over the past 7 years, there have been a number of significant events of youth violence, and that's not only shaped how we as individuals all respond to violence, but it's also going to have shaped how we've worked together in a partnership. I know some people in this room will have been involved in the direct response to some of those incidents, and perhaps what that's led to is you having to pause some of this prevention work while you focus on getting that response right. And I know there's other people here in this room that have been inspired by those incidents to move forward and try and make things better for our communities. The history of what happened in Merseyside in our organisations before the VRU was created has also influenced that context as well. So how you worked in partnership before, you moved towards prevention that were happening in some of our organisations, and a focus on place-based approaches will all have influenced how we all came together as a partnership, and also the changes within our organisation. So the VRU's had six directors over that 7 years, and every single one of them have brought their own unique skills and made their own impact on how the partnership has developed. And if you'd like to hear a bit more about context, we've got our session with our community safety partnerships in session 1A, and later this afternoon we'll have our film Dear Merseyside, which will give you a better idea of that Merseyside context. So one of the key things in partnership working is senior leadership. And when we talk about leadership, of course we have the director of the VRP who works to promote strategy and look at common approaches and outcomes. But there's also a steering group that's guiding that action. And more importantly, we've got the leaders within all of your organisations who are helping to embed the public health approach within their hierarchies. Our evaluation has told us that what a good leader should look like is someone who's got sufficient seniority to influence decisions, somebody who represents the partnership's aims and not just their own organisation, and someone who's maintains a clear vision of violence reduction. These characteristics are what help leaders drive forward the violence prevention agenda, but most importantly, they're what help to shift culture in all of our organisations. And the examples of that culture shift that we've heard most frequently when we've done this evaluation has been moving towards a more trauma-informed Merseyside and more neurodivergent ways of working, which I'm sure a lot of you have been involved with. And if you want to hear more about those approaches, we've got our plenary 3 and session 2A later this afternoon. But beyond leadership, another key factor of the Merseyside Violence Reduction Partnership is the culture that it's fostered across Merseyside. And that's one that encourages professional curiosity, experimentation and collective learning. We know from the existing evidence that a healthy, complex system is one that brings the right people together, united by a common vision and aligned with the communities that they serve. Our evaluation participants felt that the right people for Merseyside were those who already came with a strong multi-agency network, those who had a professional commitment to reducing serious violence, and who were already well embedded within their own partner organisation. But the other important thing that has helped with that model is the secondment model that's offered by the VRP. If we take people out of their day-to-day jobs and give them the time and space to focus on violence prevention, they experience a culture where they feel valued, and then they can move towards a public health approach, challenge each other, innovate, and think curiously. And that's not just a benefit to them as individuals, but it also benefits us as our partnerships. If we think that those people who've been seconded come from our own organisations, then they understand what works for us and what's not going to work. So when they come back to us with a violence prevention intervention that they feel passionate about, we trust that they know it's feasible for our organisations. So you can see how gradually over time we can build policies and activities that are going to work for us as partners across Merseyside, but also going to have a good impact on our communities. And you can hear more about that in our film that we've got at the end of the session, Preventing Violence Together, and also focus on the health system in session 1C. As well as considering who works to prevent violence, we also need to consider the how. And the final factor that has influenced the development of the VRP is their commitment to evidence-based decision-making. Over the course of our evaluation, we've seen Merseyside Violence Reduction Partnership continually develop processes and outcome measures to embed the evidence into their decision-making. So that's included establishing a data hub, looking at the risk and protective factors related to violence. It's a commitment to evidence-based commissioning and design of interventions, and also embedding monitoring and evaluation into all of their practice. Another important factor that one of our participants mentioned was also, of course, the luxury of money. Being allocated funding by the Home Office has also allowed the VRP to bring new partners together, to build capacity into our workforce to make them more trauma-informed, and also to redesign interventions and test them at a time of austerity when it might not have been possible for us to do this as partners on our own. And the outcome of this has been interventions in our schools, our hospitals, our communities, our youth justice teams, our police stations, our prisons and our employers, which work to reduce violence and respond to our community's needs. And with these interventions is coming a growing evidence base that looks at what works and what outcomes we're seeing for young people. And there's plenty... Oh dear, I've gone the wrong way, sorry. Oh no. I'm using up my whole 10 minutes clicking. How do I get back? Hey. So you can hear some more about the great work that's gone on with those interventions. So we've got session 1B, session 2C and session 2B this afternoon. So when I was preparing for this presentation, I asked Copilot to draw me a map of Merseyside. As you can see, it turns out that was a pretty big mistake. There's so many things that are wrong with this map. In fact, the more you look, I think the worse it gets. But you can see that the people of Birkenhead are living underwater. We've got our two rival local authorities of Knowsley and Knowsley, and you can't forget the island state of Garston that's floating off down the River Mersey. But I actually kept the map because I thought it was a good metaphor to finish, really. Our 7 years as evaluators of the VRP has shown us that there are things that work. There's leadership, there's that culture of mutual learning, and there's embedding evidence-based practice. That's been vital to making it work as a partnership, but no partnership is going to be a perfect picture. There are also areas where there's been challenges, so changes in our organisations, competing priorities, short-term funding are just a few of them. I think what this picture shows us is what's important for us to recognise today is that when VRUs were first announced over 7 years ago by the UK government, there was no definitive map of how to create a violence reduction partnership for our partners to just pick up and follow. Reducing violence in Merseyside is a complex issue to make sense of, and the people who've led and been part of the VRP over this time, all of the people that are going to present to you today, and everyone sat here in this room has played a role in that sense-making journey of trying to map out what it is that a violence reduction partnership can look like for Merseyside. Violence reduction is going to continue to be complex and difficult, but what we've put in place now from the VRP in terms of consistent evidence collection, a culture of learning together and leadership is vital to ensure that we continue to map out a good story of violence reduction and prevention in Merseyside. Thank you.
Thank you both, Jane and Mark. Jane, before you sit back down, can I invite you and Mark just up to the stage? We've got time for possibly 2 questions. If there's any burning questions from the audience for either Jane or Mark, just raise your hand.
If you put your hand up and then I can...
Given I've pulled them to the stage, can someone ask one question? The gentleman here, thank you. If you'd like to use the mic.
This is a question for Professor Bellis. Big fan of your work. Just one thing that always strikes me with ACEs, I guess, is the difficulty in not making it a deterministic argument that, one thing means another. And I guess for me, whenever I look at these studies, I think about what's the step after ACEs. How does an ACE translate into a need? And I guess what is the research showing in terms of not necessarily the outcomes, but sort of what are the direct needs that follow the ACE that's happened, I guess?
Yeah, I think it's absolutely critical. It's challenging in a short period of time, but I think it's always dangerous to just present even the risks and not the opportunities. So I absolutely take your point. It isn't deterministic. It should never be identified as deterministic. It's probabilistic. People are at greater risk of certain things. In some types of things, they're at much higher risk, and we do need to recognise that. Playing it down doesn't have any advantages either. I think that, I couldn't describe all the interventions, but I think sort of going back to what I was saying there, that we if you think of an increasing cycle, that we need some, at all levels, let's start with children, we need some specialist services and some specialist individuals who understand what's going on, all the way through the public sector and all the way to a certain level of knowledge in the public. I won't be able to say in detail what's there, but what I would say is as that specialist knowledge is diffused, it needs to take understanding of the risks, the non-deterministic nature of it, and the opportunities to intervene at the same time. I couldn't say more about all the other options there, but those things need to run parallel with each other.
Thank you. And then Emily?
My question is for Jade. I guess the big elephant in the room when we talk about this is the money, and you alluded to it just at the end there in terms of one of the things that the VRP brought was funding that meant we could actually really invest in some of this work. Obviously, we know that funding is going to be reducing, if not going, in the next couple of years. We know there's a lot of change in terms of the PC role going. How do you think, what does the future of the partnership look like? How do we sustain all the good work that we've done when we've got that real challenge around funding disappearing and kind of complex governance changes?
That's a nice, easy question. Thank you, Emily. I think those factors that we talked about, so I think the idea of the shift in culture that's happened, it's about sustaining that. So the capacity that we've built in our workforce, for example, in trauma-informed approaches, but lots of other work that's happened to increase skills within the workforce. So it's about now moving forward to embed the interventions within kind of the Merseyside system. That's always challenging, isn't it? And funding's always going to be an issue. But I think now that we've got the strong evidence base, it's maybe more about thinking about the next step with a lot of these interventions, which is how can they be scaled up so that they're consistent across the whole Merseyside footprint, because then that will reduce costs if it's a collaborative intervention rather than at an individual level.
Yeah, I just wanted to say, because again, it's difficult in time, but deliberately, in the information that will come out from the survey we did there, we've calculated the costs related to ACEs in exactly the same way as you calculate savings from medical interventions and other interventions that NICE might put in place. So a person with 4 or more ACEs will cost, just from the health perspective, £10,000 per year in terms of effectively lost from that. So over 18 to 30, roughly around £150,000. So that's one person with 4 or more ACEs. Now to save a certain amount of quality of life, there are rules that the government has. So and that falls well within. You wouldn't have to do much to fall well within what would be considered good value across the piece. And I think it's really important that we look for that sort of equity as well. You know, that other health interventions, other public interventions will be funded and supported on a lot less evidence and a lot less return on investment. And we just need to push back on that to make sure that we're getting our slice of the pie.
And if I can just respond briefly, it's actually the responsibility of all of us in this room to keep this model going, ensuring it's in our policies and our practices and in our thinking and how we work. I do know it's in a lot of local organisation policies and approaches, and particularly when we're thinking about trauma-informed. So again, it's not just about the VRP team, but it's about how us as a partnership continue this and continue to build on what we've done so far. Okay, so I'm going to end questions there. Jane and Mark, thank you so much. And we're now going to move on to a panel discussion, so I can invite our 5 panellists to the stage. Mark Evans, are you? There you are, thank you, wonderful. So Jane touched on before around why the VRP and the partnership works and the key elements of that. But less so due to time constraints in terms of some of the challenges and solutions to those challenges. So I've asked our fabulous panel members to reflect on some of the challenges they may have experienced in the past 6 years, but also hopefully solutions to some of those challenges, particularly when we're thinking about embedding and sustaining that public health approach to violence prevention. So I'm going to go through each panellist. You've got about 4 to 5 minutes to speak each. Can I ask you to introduce yourself to the audience before you reflect? And I hope it's okay, Tanya, if I start with you. Wonderful.
Thank you. Everybody can hear me. Good morning, everyone. Thank you, Zara. Thank you, Commissioner. And good morning, everyone. I'm delighted to be on the panel. My name's Tanya Wilcock. I'm Director of Communities at St Helens Council. I've been involved with the Merseyside Violence Reduction Partnership practically from the start, when we first mooted the development of a partnership across the region way back when I was actually working in Sefton. And then I've been 5 years in St Helens and have been involved since then. I'm on the panel and I'm here today because the reference that Jane made to leadership, strategic leadership, is really, really important. And I see this as one of the most important things within my department, and St Helens Council have acknowledged that by allowing me and encouraging me to continue the involvement in the partnership, but also in ensuring that we drive this through our community safety partnership. And I suppose in reflecting on that in the 5 years that I have been involved, I think the one thing that the challenge has always been, how do we know when things work? And the one thing I think that the partnership across the region has done has been evidencing as evaluation, and sharing that evaluation and ensuring that we all begin to know what works, use what works, amplify it, do more of it, whilst at the same time not diminishing the role of innovation and testing things within local communities and local areas, because we are all different. So we are Merseyside region, but we all have our own individual identities as places, and even within those places there are further individual identities that exist. So it's really, really important that we bring our communities and listen to our communities, and that is a challenge. And so, what are the challenges we've faced? It's the cuts, I think, to some of the engagement work that would have been prevalent 5-10 years ago, when local authorities have had constrained financial environments and we've had to make savings. It's often those relational activities, which we know are important, we logically know it, but when we're bound by responding to statutory intervention and statutory work, we end up getting rid of the thing that we know in the long term works. And that's just barmy, isn't it? But it's what happens. And so that's always a challenge. I think the other challenge from a public health point of view is moving from responding to violence, which is what we've been doing, to preventing that violence. And the response is often seen to be the role of the police. So, they come in, they respond quickly, they enforce, manage risk, etc. But public health approach flips that and says you need to work differently. You prevent the harm before it happens, before it occurs. And that sounds really simple, but actually, given the context of when violence occurs, that whole inequality agenda, poverty, childhood trauma that we've just been hearing about, if they're all not working together, and we're not involving all of the various silos that work in all of those areas to come together to strategize and intervene, then we're not going to deliver that public health approach. The prevention is less visible, it takes longer to do, and it's harder to justify both politically and financially. And that's why it's challenging, very challenging. We've also heard the funding environment, and I've named that funding environment for a local authority, but it's also been named here in terms of the long-term approach. So how do we embed this way of working as a norm? And that's a challenge. And the working in silo isn't just around local authorities, but it actually starts at the very top, governmental level. Every one of those departments have a part to play in preventing violence. So your Department of Health, your Ministry of Justice, your Home Office and Housing and Communities and local government, all those departments have a place to play, but they themselves work in isolation. So it's a challenge from the top down. I don't know how long I've taken. Are you keeping an eye on the time? And I suppose the last thing I think is that tackling inequality for me and building trust in local communities. So when we're working with communities who often don't feel the benefit of economic development, of wealth building, and who don't really feel that they've got a stake in the society in which they live, I think that's a recipe that's ripe for exploitation by others. And that exploitation is evident and visible a lot. It was visible in Belfast last night. People, we heard about childhood trauma. I can tell you very much from the accent that I've got, there's intergenerational trauma. There is people in that community in Belfast last night whose normative, legitimate response in their eyes is what their parents did and their parents before them. And the challenge for us is, how do we give people other tools so that they can be heard? And I don't think we've ever cracked that, or we struggle to crack that. So I'll leave it at that. So there's some challenges.
Thank you, Tanya. I think you went through all the challenges, which was absolutely amazing.
If we repeat ourselves, that's okay, because we're all on the same page. Everybody's area is different.
But I think that did give us that fantastic introduction to actually this is complex. A public health approach sounds easy when we look at it in paper. It's a scientific approach with some key common denominators, but actually it's hard, and we have to work together to keep that sustained and keep that momentum working. Who would like to follow Tanya?
I'll follow Tanya. Yeah. I'll keep mine quite brief. I live for the day that someone says to me, I'm a big fan of your work. So I thought that was really good. Because the truth is, 3 years ago, no one was a fan of my work. So I want to talk about challenges. 3 years ago, I wanted to change things in Knowsley. I knew things needed to change in Knowsley. We were delivering interventions that were ineffective, not evidence-based, and actually harmful. We were further normalising violence, so mass participation assemblies where someone goes in and shows kids a big zombie knife and says, but don't carry one. If you carry one, you're going to kill someone. And we needed to change our approach. You talk about challenges. I can laugh now, but I was laughed at and mocked, partly because politically it wasn't deemed to be a good approach. We didn't know as much about trauma-informed practice as we do now. And I think that financially, it wasn't something that it was going to be something that would take ages to work, and the fruits of the labour wouldn't be seen until probably round about now. So I think the solution, I think Tanya's covered loads of the solutions, but the solutions are to keep going. I'm looking at some of our victims' families today. You're my reason why. When I feel like, oh, I can't do this anymore, things are challenging, I think of you. I think of you, Julie, I think of you, Cheryl, you, Joanne, and it motivates me to make this change, because this change is something that is really needed, but it's hard. Tanya's just touched on what happened in Belfast last night. Another challenge that we have, the minute that there's an incident of violence in this city, I literally hold my hands to my face, because I know that politically someone is going to say, we need knife crime awareness back in schools, we need gun and gang awareness, we need to address this issue. But what we know is that that is ineffective. So a solution is to keep going. Dr. Harris mentioned before about the support of senior leadership. That is paramount within organisations. We have that in abundance in Knowsley. We also have political support as well. So I think there are loads of challenges. There'll continue to be challenges, but there are loads of solutions. The VRP are fundamental in the work that we do and the work that we've been able to do. Really great relationships and a great link with the VRP. They listen to what we say about what works and what doesn't work. So they've been some of the solutions. I'm just looking at the time.
It's on the screen on us. I'm happy to go next. Yes. Just to kind of build on what Francine said, so I represent Liverpool City Safe today, working very much similar roles to the others on the panel in the local authority. I think one of the big things for us is the funding gets pulled and pushed politically, depending on what the salient issue is at the time. So, you know, but we have to be aware of the interconnectedness between those issues and be able to harness the same approaches that we've developed in line with the Violence Reduction Partnership and that public health approach across all of those different issues, whether it be criminally driven violence, whether it be social cohesion driven violence, whether it be mental health or mental ill health as a kind of pandemic epidemic proportion, particularly around children and young people. I think that's our skill, and in our skill set probably to try and build those bridges between the two and make the connections, and then see that the outcomes that we're trying to achieve for broader society are exactly the same outcomes across all of those different social issues. So that is a significant challenge, because then but also a solution, I guess, to that. And I think building on what Francine was just saying there around how do we harness lived experience, and how do we harness, and make sure that we've got a victim-focused and victims' families focused approach, I guess, to everything that we do. And that can be a real challenge when you are pushed and pulled in relation to kind of, right, we want to focus on the perpetration side of things. That's where the kind of, all of the money really, realistically, up until the point of the Violence Reduction Partnership, and probably in the first years of the Violence Reduction Partnership, was all about perpetration and not about support for victims' families, and how we learn from the victims' experiences. And the crossover between victim and perpetration quite often as well. So I think there's a number of challenges that we have come across there in the practical elements of it, but there's definitely some solution to kind of melding everything that we now know under one roof. I mean, working on the violence against women and girls agenda as well. I mean, the crossover between the two around pressures of masculine social norms, and you know how that kind of builds into the violence, serious violence or criminally driven violence issues, as well as how that drives in relation to kind of cyber related violence and the perpetuation of that, those social norms, I guess, or the sense that they are social norms when maybe they're not, and they're kind of disproportionately presented to our children and young people now.
Morning everyone, my name is Mark Evans. I've worked in the justice system for over 25 years, and for the last few years I've been the head of Wirral Youth Justice. We've talked a lot on challenges. I want to kind of think about solutions as well at the same time, kind of harnessing what each individual said so far. When the justice system came around, following the Crime and Disorder Act, it was very much developed into a reaction from children who have committed offences and how to manage that situation following the reaction of the offence taking place. With the investment within the Violent Reduction Partnership and also the changes in practice, definitely over the last 5 to 6 years, it's looked at a trauma-informed way of building a relationship with a child. And that relationship, from being guided by and supported by senior leaders, allows us to work with children closer, allows us to build that relationship and create positive change. And with the support of the Violent Reduction Partnership, with what the examples have been here today, it's allowed us to allow children to be given the support in a preventative level rather than a reactive level. And it's given us the opportunity to work with children, whether they are hard to reach or communities that we maybe wouldn't be able to work in before, to create a solution where children don't access the justice system, but also get the work that is required for them. And I think that's what makes a big difference in the funding, but it's also around sustainability of that and understanding that the programmes and the work that we use influence and create change. And once you see the impact and outcomes of the actual work being achieved, then it makes it more sustainable in getting outcomes and support from other services and other organisations to sustain that positive change. And it creates from a domino effect or a stepping stone effect from senior leadership to the person working in detached youth work and the communication that they're able to do to create and make a difference for that child. Thank you.
Yeah. So I'll just come in from Sefton's perspective, really. So to build on some of what Tanya's mentioned around a community sense of belonging, we are very mindful. We will be going out to consultation for our Safer Sefton Together strategy next year. It's already been mentioned today about the VRP strategy coming out, but what are we doing with these strategies? We're all very good at writing the documents, and then what are the actions that come from them? We're very mindful that we have great meetings, there's great partnerships, that's a real strength, but we sit in a room and then what happens? What comes back from that? And I think we've all got to take a sense of ownership from that. What's our role to play in the system in terms of tackling some of the issues that we have? Having a sense of belonging is missing in some communities. No one knows the communities that they're living in better than the residents. We're very good at consulting with them, but what are we doing with the information that they're giving us? Are we just ticking a box to say that we've consulted with them and then actually moulding it into what fits, whether it's a political agenda or whether it's a leadership agenda that maybe... I think we've got to be open to challenge the kind of status quo and what's always gone before. It's not easy, it's difficult. We're using the Belong Network at the moment, who have written a policy with the local government association. So we're building a community cohesion framework for Sefton, and I know certainly Liverpool are using it as well. Engaging with partners, internal colleagues, but actually, again, what does this look like for our communities in Sefton, and how can we create that sense of belonging where people don't feel the injustice that others are entitled or getting something that they haven't got? And I think that's a really dangerous place that we're in at the minute in some situations. So Yeah, that was kind of the one I wanted to pick up on that sort of has been touched across with the others. But the main challenge I think we've all covered is the funding. So whether it's Home Office funding, whether it's Ministry of Justice, whether it's DWP, it's quite often short term. So whether it's 12-month cycles, we've all delivered pilots, we've all had that quick spend this before the end of March, show that it's worked. That's not effective, that needs to change. That's where the advocacy at political senior levels needs to happen. And we've had some shift in that in terms of crisis resilience funding, moving to a 3-year commitment from the Home Office. That needs to happen across all agendas, though, and not just certain ones. It would really support the evidence base of the work and then allowing everyone to come from a strength-based approach to it.
Fantastic. Thank you to all the panel. I was going to try to summarise everything that's been said, but there's so much covered there. But I think one of the key things from what we've heard so far, and also reflecting on that we now have a 10-year strategy for the region, is that we have a vision, a collective vision. We have collective priorities. And I always kind of try to think about, well, let's just assume there's no VRP funding. How are we embedding this and how are we embedding it? We have to do that collectively. We have to embed it in our strategies. We have to navigate those complex challenges of funding and those funding cycles. But what I can see here, not just from the panel, but actually for the whole room, is that we have strong leadership in this region for a public health approach to violence prevention. I believe that everyone in this room is favourable for that approach, and we are embedding it and we'll keep embedding it. So we have the strategy. We do have some funding through different streams, but actually we just need to embed it. And I say that like it's simple, and it's clearly not from these challenges, but we need to keep embedding it, and we need to keep that focus on our victims, our survivors, but our communities as well, to ensure that they are not, future victims and survivors. We do have 6 minutes for questions for the panel, if anyone has a burning question or anything that they'd like to add to the discussion. Lady over here.
Hello, I'm Hannah Allen. I am the Chief Exec of Positive Futures. I am a big fan of your work, Francie. So I've got an observation and I've got a question, if that's okay. I'll try to be really concise. So one of the things I've wrote down following this presentation is, how do we collectively make a stronger argument to the health to get some more money into the system? Because we talk about this is a public health approach. It's an epidemic. Why aren't health putting more money into this? It's really frustrating. So that's an observation. If you can answer that, that would be amazing. But my real question is around the voluntary sector. So you talk about funding in terms of it's a challenge. If you're running a voluntary sector organisation, bloody hell, it's a challenge. 12-month funding, no cash reserves. It's really, really hard, and we try our hardest to participate in strategic discussions, be involved in strategy, come up with innovation and solutions. I am personally very committed to this agenda, but it's really hard. And what I'm not seeing is outright commitment from local authorities to say, we want to mobilise the voluntary sector. We know that you bring innovation, match funding. How can we help you? And I've got loads of examples of how that has happened, by the way, from people on this panel today. But it needs to happen more. And not just with certain organisations, but collectively the voluntary sector want to respond, but needs help to do that.
Okay, so I'm going to ask the panel to respond to the second question. And if Nicole Mishra's in the room, I'll ask them to respond to the first question in a moment.
So thanks, Hannah. I think you're absolutely right. I mean, it's incredibly challenging. The funding situation for voluntary sector organisations is just, it's for years and years. I mean, since the dawn of time, probably been like this, hasn't it? And it's kind of, I guess, our responsibility from a point of, we are then, I guess, the purse string holders in our roles, our responsibility to harness the way that the voluntary sector is quick to enable. And I think that we do that generally, but we possibly do have an over-reliance on that ability to mobilise really quickly when we can't mobilise quickly in a statutory body. So I think there's real value there, and probably a lack of recognition that is a valuable a valuable relationship, but also the toll that takes on the voluntary sector then, and the possible, the general wastage of money, realistically, in what goes into that, in relation to kind of, could we have done something earlier in the financial year sort of thing, and we're always battling with that. I think sometimes we don't know how much money we've got until, left until the very end of that financial year, and it would be great if we had that flexibility to kind of move between financial years, in all honesty, because there's always a scrabble at the end of that. But I think in relation to kind of how we bring voluntary sector organisations together, I think there has been a gear shift in that in relation to violence particularly, because in 2019, I can remember we started doing communities of practice, and we tried to bring voluntary sector organisations together around violence, but a lot of organisations did not recognise the role that they had in that prevention space, and that has changed. And like what you were saying there, Hannah, I think that's definitely changed in relation to kind of the passion and the specific, and the changes in, short-term funding for voluntary sector organisations also means a high staff turnover. And so then you also have new individuals coming in with different passions and different ways in which they want to approach things. And that's something that also almost needs a bit of a strategic approach across the voluntary sector to say, we are collectively going to take this approach, and this is how we're going to feed into this 10-year strategy. So there is also a bit of an ask, I guess, for voluntary sector leadership and the coming together to try and build that bridge between those two worlds, I guess, between the statutory and between the voluntary sector.
Tanya, would you like to come in?
Yeah, so I think this has been recognised, isn't it, and it's changing in pockets. So this year, local authorities have been given a 3-year settlement for housing and domestic abuse funding. Now, that's been brilliant, 3 years, because that then enables us to say to our partners who are delivering in the voluntary sector, we can passport that to you. I think Emily, as the Police and Crime Commissioner, acknowledged that it was really important to give community safety partnerships 3-year funding, so that, a commitment to funding over a 3-year period, which then gave us the opportunity, even though it's smaller amounts of funding, it gives us the opportunity to passport some of that onto our voluntary sector and say, we're going to commit to this. Obviously, like all funding, you review annually, but if you're delivering, you continue to get the funds. So I think it is starting to change, but it's not quick enough, fast enough, and probably not even long enough. But then governments are only in power themselves, 5 years? So it's difficult in that respect. But for us to get even a 3-year settlement now, the problem we've got with a 3-year settlement is that it doesn't increase with inflation. So in effect, over the end of the 3 years, it's probably a decrease in funding. But it's like they give with one hand, take with the other. But the important bit is it's longevity, and gives us the opportunity to think longer rather than short-termism. But yeah, you're absolutely right. We feel it, so we passport it to you. So if it works for us, we're passporting it to you, and it works for you. But if we're not getting it, and we're getting 12-month funding bids, it's passporting to you for probably 9 months delivery, because by the time we get our procurement and processes right to give money out, you've even less time to deliver. So that's the struggle and the challenge.
Thank you both. If I can just go over to Nicola to respond to the first question.
Thank you. So Nikhil Misra, I'm the health lead at the VRP, and I'm a consultant trauma surgeon at the Major Trauma Centre at Aintree. So why isn't health providing for a more financial input? Where is the impetus for healthcare to actually step up? And that's an absolutely fantastic question. We have to be very realistic about the healthcare economy, both locally and centrally. It's broke. We're being asked to deliver the same amount of healthcare with less money, but the volume of work has gone up significantly. And I think it's really important to understand that this then translates down to a frontline situation where shifts go unfilled, wards don't get staffed, nurses don't get hired, stuff doesn't get done. And then on top of that, people like myself and a lot of people in the room are saying, actually, we need to put a lot of money and thought into violence prevention. So this is probably the biggest challenge that we have in healthcare, is to how we deliver healthcare, but actually make this a priority based on all of the brilliant arguments about longevity, quality of life, and the economic benefit. It's really difficult for that to land in a situation where doctors, nurses and wards aren't being funded.
Thank you. I'm going to pause on question there, if that's okay, if you can take it into the break. I'm going to thank all our panel for the time, and I'm going to move on to our final section. Thank you. So I'm now just going to play a short video that was produced by students at Liverpool John Moores University, really to tell the story of a public health approach to violence prevention. They are in the room. I don't know where they are, but if they can just wave. They were here earlier. Or maybe they don't want to wave. But anyway, very appreciative to our students for making this film. The public health approach treats violence like something we can prevent, not just something we react to. It very much aims to address the underlying causes of violence. It aims to strengthen protective factors for violence. Following the evidence on what works and intervening early in life, the aim is to prevent violence across the whole community.
It's so important that we adopt a public health approach because violence is preventable. You know, we want to live in a world where we can stop violence from happening. And taking a public health approach means that we get upstream of that. And I think it's also not just about the police, it's got to be about every agency. It's about everybody playing a role, ultimately, so we can prevent violence from happening in the first place.
It's not enough to just address violence as and when it occurs. We need to prevent violence before it occurs. And a public health approach allows us to do that.
Well, Merseyside Fire and Rescue Service use a public health approach because we often see the consequences of violence firsthand. Preventing violence is more effective than simply responding to its consequences. And by working with partners to tackle the root causes and support early intervention, we can help create safer communities.
I think violence is something that can be very personal to an individual. We have traditionally always defined it as something being quite physical, but more and more we come to understand that violence can be something much more internal.
Definition for serious harm is an event or incident from which recovery is either difficult or impossible. And I think that way about serious violence.
Critically, it's not just about physical abuse. One of our recent studies found that verbal abuse of children is equally as impactful as physical abuse. Therefore, we need to consider all types of abuse when we're looking at prevention.
So it's really subjective, very difficult, and I think when we speak to our communities, and particularly if we're talking around serious violence, they often see it more as that physical acts of violence, or for example, knife-enabled and firearm-enabled violence. So our serious violence definition really encapsulates all of that really, so it's a really holistic view of violence.
We're doing loads to embed the public health approach here in Merseyside, primarily through our violence reduction partnership that brings together our police, our probation, but also agencies like the DWP. How do we engage them in terms of jobs? How do we work with our schools, education providers? How do we work with our healthcare providers? We've supported thousands of young people around really crucial interventions, but actually we go even earlier than that. We're supporting pregnant women. How do they understand how to give their child the best start in life, but also through to people who are maybe more embedded? How do we identify those drivers? And we're investing in programs that, you know, help them to tackle their reoffending. So it's about looking at every different element of where people come into contact with us as services. We're taking the opportunity to stop the reason for their offending.
Merseyside Fire and Rescue Service actually deliver two programmes. One's called the Beacon and one's called the Fire Champions. Both of these programmes are funded by the Violence Reduction Partnership. By intervening in a proactive way, we're helping children find the right positive path as they journey into adulthood. We use a trauma-informed approach, and the intervention aims to improve school attendance while also reducing the number of those excluded from mainstream education. It encourages children through physical activity rather than a classroom-based learning.
An example from healthcare will be the campaign that we run on Life Savers. We go to schools, to colleges, to secondary educational institutions. We go to the bars and the clubs around the city and the region to talk about, from our lived experience, the consequences of carrying a knife and a single knife wound. This is our lived experience as clinicians. We see the consequences of a single knife wound and therefore can communicate that to pretty much anyone and everyone. Now, wrapped up inside there is also a health message. We teach young people how to stop bleeding from any cause at all, to save as many lives as possible.
So the RAISE team, as mentioned, we work on the mental health and violence prevention programme. So that is a active bystander programme which uses a peer education model. So it is older students talking to younger students about violence prevention. We really look at what are the attitudes and beliefs and social norms that underpin gender-based violence, abuse, other forms of bullying that might happen. And we start to think about what some of those bystander options could be that those young people could take.
We have a programme of delivery called Be the Change. And the ethos behind Be the Change is that we believe that in order to address serious violence, we need to tell children and young people and our residents what they can be. There is a strong evidence base to say that positive interventions that come from a place of strength, are those interventions that are most effective. Children know about violence, children can access violence online. Why aren't we going into schools and talking about all of the amazing opportunities that are out there for children and young people?
In healthcare, we can make a difference. We don't fully appreciate the difference that we can make, that we are listened to, that actually, if we pause and think about the person in front of us, we can actually make a big difference.
Violence is preventable and not inevitable. By addressing the root causes early and working together, we can stop harm before it actually happens. Prevention saves lives. Tackle the causes, not just the consequences.
We can't arrest our way out of serious violence. We have to tackle the root causes.
So if we really want to adopt a public health approach to serious violence across the city region, then we need to be the change. We need to be the change as leaders. We need to be the change as residents. We need to be the change as community members. We need to work together.
Through taking an evidence-based approach, supporting our children, our families and our communities, we can ensure they live safer and happier and healthier lives. Prevention starts with all of us.